Thank you for the opportunity to present our work. Here are our disclosures. Ruptured abdominal aortic aneurysms remain a challenging clinical entity to treat, with an associated high morbidity and mortality that oftentimes requires the significant mobilization of resources both in the pre-hospital and in-hospital settings. And this risk score calculator remains a very valuable tool not only in counseling patients preoperatively regarding their operative risk, but also in helping guide transfer and treatment decision-making. Various risk scoring tools have been created, but they all vary in terms of their reproducibility and effectiveness based on the simple fact that some of them are overly complex and not practical for use. Others rely on intraoperative or postoperative variables that are entirely worthless to the patient prior to the operation, and some of them are just simply not accurate outside of the initial study that created them. The Harborview risk score, which was created at our institution and published about in the Journal of Vascular Surgery in 2018, is an entirely preoperative risk score based on these four factors: age greater than 76, creatinine over 2, pH less than 7.2, and any episodes of hypotension with a systolic blood pressure less than 70, in which the published 30-day mortality is 22% if 1 point is present, 69% for 2 points, 78% for 3 points, and a 100% mortality if all four factors are present. The objectives of the current study were to not only examine the outcomes of modern open and endovascular repair of ruptured AAA, but also to examine the accuracy of the Harborview risk score with regards to predicting 30-day mortality in the modern ruptured AAA patient. And we hypothesized that despite advancements in endovascular techniques and improved mortality following ruptured AAA repair, the Harborview risk score will still accurately predict 30-day mortality after both open and endovascular repair of the modern ruptured AAA patient. To answer these questions, we performed a retrospective review of a prospectively collected database that includes all patients who present to our institution with a ruptured AAA, and we reviewed information such as baseline demographics, pre-hospital transfer data, and postoperative outcomes. We divided the patients into 3 cohorts based on when institutional practice changes occurred: the pre-EVAR era, during which most of the repairs were done open; the pre-risk score use era, during which an endovascular first approach was used, however there was no risk score that had been developed; and the modern era, in which the primary outcome of this study was 30-day mortality within that third cohort. And just as a reminder, the Harborview risk score was created based on the mortality data published in that 2018 study, which is based on the mortality of cohorts 1 and 2, and the objective of the current study is to validate the risk score in cohort 3. Over the 17-year study period, 417 patients were treated with ruptured AAA, with 391 undergoing an operation. When we look at the characteristics of all patients, we see that the majority are male, 80%, with an average age of 74. We also see that 61% of patients underwent an open surgical repair, with 38% undergoing an EVAR. In varied analysis, we see that open surgical repair is associated with an increased risk of 30-day mortality, with an odds ratio of 2.8. And being repaired in a later cohort, either 2 or 3 as compared to 1, is associated with a decreased risk of 30-day mortality. With regards to the risk score, we see that not only is each individual component associated with increased 30-day mortality, but so too is the Harborview risk score as a whole. Other variables associated with increased 30-day mortality include heart rate greater than 110 and INR over 1.8. We found that, interestingly, AAA diameter and transport by helicopter were not associated with worse mortality. On multivariate analysis, we found that repair type, as well as the HMC risk score, INR greater than 1.8, and heart rate over 110, all remain statistically significantly associated with increased 30-day mortality, whereas cohort no longer does. When we look more specifically at the cohorts themselves, we see that as we progress over time and move from cohort 1 to cohort 3, we see that a higher proportion of repairs are done through an endovascular approach, which is shown here by the gold bars. We also see that over time there's a slight decrease in the average Harborview risk score for both open and endovascular patients, and we see that there is no difference in risk score between the two groups across all 3 cohorts. We also see that as we go from cohort 1 to cohort 3, 30-day mortality decreases from 58.6% in cohort 1, again shown by the gray bars here, representing all patients, down to 35% in cohorts 2 and 3. This is driven both by an increased adoption of endovascular techniques as previously shown, but also by a decrease in the mortality of open repair, which was shown by the purple bars here, which decreased from 58.7% to 40% in cohort 3. When we look specifically at the risk score within the modern cohort, we see that when we look at all patients combined, as well as each patient by repair type, that the increase in a Harborview risk score is associated with an increased 30-day mortality. Additionally, when we look at the risk score among all of the patients in the modern cohort, we see that a score of 1 corresponds to a mortality of 35%, score of 2, 68%, and a score of 3 or 4 associated with a 100% mortality. When we look further at the accuracy of the Harborview risk score, one of the main critiques with regards to all of the risk scores is that they are a variable or a predictive tool that is based off of a retrospective review of already collected data that we then try and prospectively apply to patients. And one unique aspect of this study is that we were actually able to take our previously created retrospective risk score and apply it in a prospective fashion. And what we found is that the area under the curve of the two ROC curves, the ROC curve of the development cohort or that initial study on the left, and the modern cohort on the right are similar. And in fact, the AUC is 0.75 in essentially both cases. The Harborview risk score, therefore, is accurate among our modern ruptured AAA patients, which, again, as an entirely preoperative risk score, remains very valuable in preoperative counseling and treatment transfer decision making. And this is a finding that has been confirmed by multiple other groups, including these two from New Jersey and Denver, which found area under the receiver operating characteristic curves of 0.74 and 0.79, respectively. In conclusion, this represents the largest single institution experience with ruptured AAA, in which we saw over triple the odds of 30-day mortality following open surgical repair compared with EVAR. We also saw that following the institution of an EVAR first approach, mortality dropped from 58% to 35%, which is likely a reflection of both increased adoption of endovascular techniques, but also due to increased mortality following open AAA repair. We also saw that the Harborview risk score is accurate among the modern cohort, which is consistent with studies performed at other institutions. We found that the majority of patients are transferred, thus only highlighting the importance of an accurate risk score in guiding these transfer decisions, and that the most likely variable missing in the risk score is the pH, so it's important to get an ABG early. Lastly, we identified two variables, INR and heart rate, which might be added to the preoperative risk score and could further increase its accuracy. Thank you. Be happy to answer any questions.